sleeping better. One of the interesting parts is that every day I get people complaining about sleep and I can't breathe, and this is actually a great struggle. The best way to fall asleep is watch one of our webinars, and that will put you to sleep. So that's the first message. But in reality, is that many of us are struggling with sleep, and the team led by Hannah's put together a wonderful presentation. A good colleague and friend, Dr. Raymond Gottschalk, is a real expert. I heard him talk many times, and I really love what he has to say. So I'm glad he's here to give us his insights as well. So Hannah, take it away.
Sure. Hi, everyone. Welcome to this week's webinar. I know it's on a Tuesday evening, so not our typical day to be hosting webinars, but we're really glad you've joined us and are watching this video. So as Dr. Kearney mentioned, we have a special guest today who's going to be providing his commentary about his experience with sleep disorders, and I'm hoping you'll enjoy this presentation. So just to provide an overview, we'll be covering why sleep is important for our health, why getting sufficient hours of sleep is important for our sleep cycle, a few sleep disorders and treatments, including the CPAP machine, the usage of medications versus supplements, including melatonin, and ways we can have better sleep hygiene. All right, so to help us in learning more about sleep, we're very fortunate today to have Dr. Gottschalk join us tonight. Dr. Gottschalk is a sleep disorders specialist, respirologist, and internist who has an interest in a wide spectrum of disorders that affect sleep. He has been the medical director of the Sleep Disorders Clinic in Hamilton since 1994 and is a diplomate of the American Academy of Sleep Medicine. With his expertise, he assesses other sleep clinics on behalf of the College of Physicians and Surgeons of Ontario and has co-chaired guidelines in sleep medicine for several years. We're very grateful to have him here as he'll be providing his oversight and commentary about all things related to sleep. Dr. Gottschalk, if you have a few words, please go ahead.
Well, thank you for that very kind introduction. And certainly sleep medicine is a very, very fantastic specialty because it includes everything. Almost everyone has a sleep issue, and especially given since COVID has hit, we now have a new syndrome called COVIDsomnia or COVID insomnia, which has increased the prevalence of sleep disorders, mainly insomnia, up to 60%. So this is very timely, this presentation, and having read through their presentation, seeing all of the lovely clues that are being given to us to improve our sleep, I think everyone will benefit enormously from this presentation. Thank you.
Thank you so much.
I had the pleasure of knowing Raymond for many, many years. I heard him talk many times, and it always stands out. He gets really to the meat of the presentations. He knows how to take good concepts and how to make them understandable to all of us. So, we're gonna show you how to get better sleep, and let's move forward there. Thank you for working with us tonight.
My pleasure.
Yes. Thank you so much. All right, then with that said, we'll get started. So first, we're just going to be covering why sleep is important. So according to the National Sleep Foundation, adults 18 to 64 should be getting 7 to 9 hours of sleep each night, while adults 65 and over should be getting 7 to 8 hours of sleep. However, when we look at Statistics Canada results, we find that 1/3 of Canadians get less sleep than recommended. And in fact, among all Canadians, the estimated amount of hours that are slept each night is just over 7. 43% of men and 55% of women have trouble falling asleep or staying asleep, sometimes, most, or all of the time. And 33% report difficulty staying awake during normal waking hours. And in a couple slides, I'll be talking about why that's so dangerous. So why is sleep important? According to the restorative theory of sleep, we know that sleep plays an important function in allowing our body to repair tissues and replenish the energy we've lost throughout the day. It facilitates muscle growth, protein synthesis, and helps with growth hormone release. And as such, sleep is directly linked to our exercise and nutrition because if you think about it, if we're feeling fatigued, we're going to be less inclined to go for that run, and that in turn will reduce our physical activity. And if we're feeling more stressed or irritable, we might turn to snacking or overeating to compensate for those negative things. And so given this, even though sleep is critical to our health, in the 2018 Sleep in America poll, we see that Americans tend to face favor fitness, nutrition, work, and hobbies and interests over sleep. So we see that sleep is only 10% of their priority compared to those other factors, which just reflects the need for more talk about why sleep is important and how we can do it better. So while this is not an exhaustive list of health concerns associated.
Let's just pause for a second. Go back one slide there.
Sure.
This business, how much sleep you have. Can you just go back one more? Raymond, I was at a different talk recently, and I was struck that a newborn sleeps about 16 to 20 hours, where people age 65 on average is about 6 hours, and our sleep patterns do change. People get fixated on these numbers, and some people sleep 3, 4 hours, some people sleep 8 hours, and how do you tell people if they're getting enough sleep? They seem to want to get a number of hours a day. Is that really important?
Yeah, that's a brilliant question. And so the issue for most people, we know that the distribution of height follows a bell curve, the Gaussian distribution. And the distribution of sleep requirement is the same thing. There's a bell curve where some people need as much as 10 hours sleep, some people can get away with 6. And so when you try and force everyone, the crime of procrustes, to make them all fit into your mythical 8.5 hours, it doesn't work. Some people are more efficient in their sleep than others. And so as the purpose of sleep is really mainly for the brain, it's a function of the brain, by the brain, for the brain, largely, and we increase our cerebrospinal fluid, so-called lymphatic flow during sleep, acting like a car wash to wash out the tau and amyloid protein that develops during the day. And so that process in some people is done very efficiently, in other people it's not. And so really you can only gauge whether you're getting enough sleep is how you're functioning the following day. So if you're not sleepy the following day or feel you need a nap, you are getting adequate sleep as long as you're not over caffeinating or using some other type of stimulant to keep you awake.
Thank you. Go ahead there, Hannah.
Sure. Yep. All right. And although this is not an exhaustive list of health concerns associated with sleep deprivation, I did just want to provide a bit of a glimpse into why sleep overarches a lot of the other aspects of our health, including our heart. So sleep deprivation puts individuals at risk for higher blood pressure and coronary heart disease, and raises other risk factors such as obesity and diabetes. So a lack of sleep has been associated with increased insulin release and increased ghrelin, which is the hunger hormone that tells us we're hungry, and lower levels of leptin, so the hormone that tells us we're feeling full. So in effect, when we're sleep deprived, we are feeling very hungry without ever feeling full, and that can contribute to obesity. Furthermore, we know that in research, diabetes, individuals who are sleep deprived have a 3 times higher risk of developing type 2 diabetes because of impaired glucose control, as I mentioned with the insulin. And not sleeping enough also weakens our immunity because it increases cortisol release, and cortisol is also known as a stress hormone. It also increases inflammation and sugar cravings, which can also weaken our immunity. So all of these in excess are more damaging than beneficial for our bodies and health. And given these consequences, we know that sleep deprivation is associated with the likelihood of several different cancers, including breast, colon, ovaries, and prostate, as well as death, highlighting the long-term effects of insufficient sleep. And Dr. Gottschalk, if you have anything to add there, please go ahead.
No, what you've really outlined is that the restorative function of sleep is basically surveillance and cleaning up. The brain is sort of like New York City, where at night people put out the garbage and that garbage gets removed. And that's in essence what happens during sleep. The brain, as I said, the lymphatic flow, the cerebrospinal fluid increases, washes everything out, and the immune system reconstitutes. And if you are stressed and the immune system is looking for other aspects to deal with, it's going to ignore the changes, the carcinomatous changes that happen in all of us. We're developing cells all the time that are wrong, and they get removed. So when we are sleep deprived or we push through a shift work type disturbance, this neoplastic surveillance is impeded, and hence the higher risk of cancer. And in fact, certainly we see that much more clearly outlined in shift workers who are working night shift. And in fact, the Danish, I believe, were the first people to actually provide compensation for people who developed malignancies that were felt to be related to shift work.
I really like that metaphor you use with New York City. I think it reminds me of Dr. Kearney always talking about how many thoughts are running through our heads.
Yeah.
Yeah, definitely a great, I think, comparison. And just to add on to that, there's a lot of cognitive effects of sleep deprivation, and that includes a lot of domains within our cognition. So it facilitates memory consolidation, which is why when we're deprived of sleep, it can lead to more forgetfulness and a higher risk of dementia. And earlier, I mentioned that lack of sleep is associated with increased stress hormone release, and obviously that can influence our mood as well. And if we're experiencing more irritability, that also puts us at more risk for anxiety, depression, and strained relationships. But I think the most eminent danger of sleep deprivation would be in our perception and coordination. So by feeling less alert, attentive, and having more impaired judgment and even daytime sleepiness, as Dr. Gottschalk mentioned, and slowed reaction time, we know that this is associated with increased risk of getting into a motor vehicle accident. So much so that the CDC says that drowsy driving is similar to drunk driving. And I think Dr. Gottschalk really brings up a great point about the shift work and really the danger in not getting enough sleep when you're on a different type of schedule that may not necessarily work with your circadian rhythms. Perfect. And I know Dr. Kearney wanted me to add this image. If you have anything to say about this one.
This is obviously the all sleep in one slide, and what it outlines is the impact of sleep deprivation from an insomnia, as it's stated here, the social impact. It obviously causes problems with your partner. The environment is incredibly important. I have a lot of patients who have pets sleeping in the bed and they run on different rhythms and disturb them. In fact, I had one guy who had a pot-bellied pig that would sleep on the bed. And eventually the pig got so big that it was either him or the pig who got the bed. But there are other things that people start getting more anxious, and they start using the bedroom as a worrying zone, which is exactly the antithesis of what you want. You want your bedroom to be the quiet zone. Medications and drugs, we all understand alcohol makes you dozy, but your sleep gets destroyed. Sleeping pills don't make you sleep much better generally. Caffeine is a problem. And all of the other drugs, and there are tons of others that have an impact on sleep. And so then you have the other things that are specific to women, such as menstrual changes in sleepiness and menopausal changes. And then the slew of psychiatric issues such as anxiety, which is almost like having a couple of hamsters running on a wheel in your head and sleeping this process. The analogy that I use is that let's go to Toronto instead of New York, because I love Canada more. And so Toronto is your brain. And you have the 401, 403 highway going into Toronto. That is your alert highway. And you've got little highway 27, which is your sleep highway. And that's only a little 2-3 lane highway. And so for most people, it's that excessive traffic on the 401, 403 that is disturbing the brain's ability to settle down. And the little sleep highway, we almost never get a deficiency there. But when we try and push more traffic down the small highway, what are you going to do? And you're going to block it up and you're going to cause a traffic jam. Whereas on the 401, 403, if you can reduce the traffic flow by reducing that anxiety, the hamster, all of that hyperexcitability, can't switch it off type of syndrome, that is the process that we use to try and treat the insomnia disturbance that you described there.
Wonderful. And I'm just wondering, do you have any suggestions or advice for people who kind of should be or trying to find ways to manage their anxiety outside of the bedroom? So would it be more beneficial to set like a worry time, for example? What are your thoughts?
That is very individual, because some people, if they set aside a worry time, and then they worry that they haven't made a complete list. So it depends on the compulsive behavior that the individual has. But certainly dealing the basic backbone of insomnia management is with cognitive behavioral therapy for insomnia, which is really to try and re-educate you as to how to approach it. We've developed the syndrome of wanting a fix that takes very little effort. We see how tough it is for people to stop smoking, to lose weight, to adhere to medications, and to adhere to anything that doesn't rely on a pill. And for doctors, it's very easy. A prescription is much quicker than going through a detailed enunciation of all the steps you need to take. But the cognitive behavioral strategy for insomnia is the backbone and should be. You use it for anxiety, you use it for depression, you can use it for OCD. So all of those things, and that needs to be evaluated by a clinical psychologist or psychiatrist with expertise in those zones.
Amazing. Thank you. And later on, we'll be talking about some resources for that.
So I heard this word cognitive behavior therapy. What does that mean?
Well, cognitive from thinking, behavior, altering your behavior, and therapy is the person who's going to be guiding you. And this can be done. So in essence, what it does is it tries to deconstruct the construct that people have made, because most people say, I go to bed, I'm sleepy, I lie down, and whoops, I'm wide awake and alert. So they've developed this aberrant reaction to the bedroom. And so what they do, everything they do is intuitive to them, but is counterintuitive to sleep. They spend more time in bed. They then get anxious about going to bed. They try and then, try and get some over-the-counter medication, which doesn't work, or it does work for a while. And so these things just then snowball until people have developed a full-blown insomnia disturbance. Now they have superimposed anxiety. And so unless you can unravel all of those things, and I think the best thing for anyone in their life to have for a short while is insomnia. I had it when I was in my second year of medicine, couldn't get to sleep, I couldn't stay asleep. So for me, this is absolutely marvelous. I can empathize with patients who say I can't sleep because I know what it felt like. And so to understand their distress, and their distress is real, and trying to get them to change their frame. So in essence, there are 4 little recommendations that we provide the short course therapy of CBT for patients. We tell them spend less time in bed, because the less time you spend in bed, the more you can consolidate your sleep. Get up at the same time, because that sets the circadian rhythm. Don't get into bed until you are sleepy, because going to bed not sleepy is useless. And if you're not asleep within 15 to 20 minutes, get up and go and read something boring, a magazine or The Economist or whatever, and then go back to bed when you are sleepy. So it's basic. What we know in medicine, not every construct works for everyone. And when we try and adopt a baking recipe for medicine, we fall very, very far short of an ideal. People are different. And, McMaster, bless their heart, did come up with the concept of the N of 1. You trial the individual with that therapy to see if it works. And that makes a lot of sense because people are different. And if you try and use your experience from your last patient to the next one, very often it won't work. So you need to have a panoply of options available. But the cognitive behavioral therapy is really a sort of breakdown of letting people understand that spending too much time in bed worrying about it, explain to them what sleep is all about, explain to them how the brain does it, how they need to reduce the hyperexcitability. And that takes a while because you need to deconstruct a lot of their bad behaviors.
So, thank you so much. All right, so having talked about why sleep is so important, I'm going to give it off to Hareen to talk about the sleep cycle.
So basically, when we fall asleep, we tend to go through a cycle of sleep stages. And these stages fall under 2 main categories. So the first being rapid eye movement sleep, or REM sleep, and the second being non-REM sleep, or non-rapid eye movement sleep. So REM sleep only has 1 stage, but non-REM sleep has 3 stages. And each of these 4 stages is linked to a specific brainwave and neuronal activity, and this is seen on the picture on the right. And they also each serve a different purpose. So when you're asleep, you cycle through these stages approximately every 90 minutes by going from NREM1 to NREM2 to NREM3, then back to NREM2 before entering REM sleep. And this pattern repeats over and over and over as you sleep each night. So, however, though, as you sleep, the time you spend in each of these stages within your 90-minute cycle also changes throughout the night. So, for example, the longer you sleep, the longer and deeper your REM periods become in comparison to the other periods and stages of sleep as morning approaches. And this is something we'll explore further on the following slides. So when you first lie down to fall asleep, the first stage you enter is non-REM 1. And this marks the change from being awake to falling asleep. And this can be marked with a distinctive difference in your brainwave activity, and this is seen on the image to your left. So you can picture it as a short period of light sleep overall, and it lasts for several minutes where your heartbeat, breathing, and eye movements all slow down and your muscles begin to relax with only occasional twitches. Your brainwave activity also begins to slow down, and this is seen in the image. Interestingly, this is also a stage you may remember seeing images or hallucinations. So if you've ever woken up remembering the sensation of falling or floating, it's most likely because of this stage of your sleep, as these hypnagogic sensations are also often incorporated into your memories. The next stage you enter is stage 2 of non-REM sleep, and this marks the period of life sleep right before you enter a state of deeper sleep. Your heartbeat, breathing, and brainwave activity all slow down even more, and your muscles further relax. So on average, in a 90-minute sleep cycle, you spend around 20 minutes of your cycle in NREM 2, but this allocation increases as the night progresses. And it's estimated overall each night you spend around 50% of your time sleeping in this particular stage. And the key feature of this stage is that there are random quick bursts of electrical activity in your brain called sleep spindles. And these spindles aid in monitoring the information our brain receives about our external environment and how responsive we are to the sensory stimuli around us while we're asleep. So the next stage that we enter is a period of deep sleep known as stage 3 non-REM sleep, and is what you rely on the most to feel refreshed and energized in the morning when you wake up. So your heartbeat, your breathing, and your brain waves all slow down to their lowest levels during this stage, and your muscles also become even more relaxed than before. And on average, it lasts for 30 minutes in a 90-minute cycle, but this duration decreases as you go through more and more cycles until you eventually stop entering this stage at all in your cycles. This is also the stage where it is hardest for someone or your surroundings to wake you up as you're in your deepest level of sleep at this moment. REM sleep is the last stage that you enter, but you enter this by going back to NREM 2 first. So it lasts for about 10 minutes where your eyes move rapidly from side to side behind closed eyelids. And in this stage of your sleep cycle, your brainwave activity becomes the closest to resembling what they are when you are awake. So this is mirrored in things like your heart rate, your breathing, and your blood pressure, all becoming faster and more regular when compared to the slower and relaxed levels they are in your NREM sleep. This stage is also where you dream the most, but it is also possible to dream in NREM sleep as well. So when in REM sleep, your arm and leg muscles become temporarily paralyzed, which prevents you from acting out your dreams. Though you may not always remember your dreams, each night you spend about 2 hours dreaming on average. So what is so important about dreaming? The exact purpose of dreaming isn't actually known, but is thought to help process your emotions and events that are occurring in your daily life. And a fun fact is that some people dream in color, but others remember dreams only in black and white. If we want to go on, yeah. So now that we've gone through the various sleep stages in your sleep cycles, it's important to address that your sleep itself changes as you age. As you age, you will find that you have a decreased ability to maintain sleep, meaning that you will awaken more and for longer periods of time throughout the night. And this is seen on the graph where the top graph models an average sleeping period of a young adult and the bottom graph of an older adult. As you can see by looking at the level
Hello?
where the individual is awake,
Hey.
older adults on average wake up more frequently, but the decrease in sleep maintenance is thought to plateau at around age 60. Sleep duration also tends to change as the total time you spend sleeping changes as well, from childhood to older adulthood. The time decreases with age as well, from pediatric to older adulthood as well. So the third major change
Okay.
that occurs with your sleep is as you age is the changes in the amount of time you spend in each sleep stage within a single cycle. Overall, as you
Okay.
age, the
Alright, so
amount of
I'll
sleep you
just
spend in
I think
NREM
we have
1
like
and
2 minutes, so I'll
NREM
just let
2
them know and
increases,
then
while NREM 3, which is your deeper stage of sleep,
okay.
and REM
Alright, for sure.
decreases.
Yep, no
So the
worries.
following picture
I'll
on
do
the
it right
next
now.
slide
Alright, bye.
basically models the same thing. So as you can see, the size of the body basically indicates how long you're asleep for. And as you move from being a newborn to a senior, you can notice that the average amount of time you spend sleeping decreases, as well as the proportions of the different stages changes as well. So like purple representing REM, light blue representing deep, the pink representing medium and light sleep, and then yellow representing the amount of time you're being awake for.
So I find this slide quite interesting. That as you get older, you tend to sleep less. Is it because you need less sleep, or is there something else happening there? And I notice as I get older, as you well stated, is that my sleep becomes more fragmented. I wake up more and I fall back to sleep, whether or not to.
Oh, all right. Sorry, everyone. I think there was a limit to the WebEx meeting, so I was trying to get everyone to join back again, and then we can restart the presentation. Sorry about that.
Sleep there, huh?
Yes, I think because we're not using I think since we're not using Stuart's account, I think my account has a limit, 1 hour limit, so we have to just everyone just rejoin and we can restart the
Sure.
presentation.
Okay. Tell us when you're ready to restart there, Jerry.
Yeah, for sure. I am ready whenever everyone joins. I think once all the members from Hannah's team joins, we'll be able to restart again.
Just share my screen while we wait.
So I'll start in again, and we can put that slide back there. Okay.
Mhm.
We don't have Stewart's version, do we?
No,
Okay. How long do we get on this one?
I think an hour more, so until 8:30, I think
Okay.
you'll have
Okay.
to
All
end
right.
again.
Okay. Are we ready to relaunch?
Yep, we're ready.
Yep, whenever you guys
Whenever
are
you're ready.
ready.
Okay, go ahead. Are you going to count us in, Jerry?
Yep. So 3, 2, 1, and we are good.
Well, you know what? I just had a little sleep break there for a second. You can see how technology always works or doesn't work. And we were saying this, and Raymond, is that as I get older, um, I'm becoming more fragmented. I seem to have to wake up at nighttime, and I want to have something to have a little snack. And I find if I have a little snack, it puts me back to sleep. Is that just more in my head, or is that a learned behavior? Is that any physiologic reasons? Hannah and others know that I'm a nighttime eater, so I'm trying to figure ways to eat less at nighttime. Do you have any thoughts about that,
Uh,
Raymond? Why do I?
that's really quite fascinating. What we do recognize with aging is that our sleep does deteriorate. And the analogy that I use, having grown up in Africa, is that as we get older, we like the older lion and have to be more vigilant because the younger ones are going to come and attack us. So we tend to wake up more vigorously and much more easily. Now, the problem with that is that as you age, you spend more time awake across the night as well. It's not only that you wake up more frequently, but you spend more time awake. And one of the difficulties is that with the aging process, there are many things that interfere with your sleep, such as pain, such as medication, such as a noisy spouse, and also having to get up to urinate. And certainly, if you teach yourself to eat at night, you will eat at night and you will naturally wake up to eat. So that becomes a very slippery slope. Consumption of calories during your sleep time is a very bad idea generally because it does become a learned behavior. Now, one of the other aspects of this is that we use deep sleep as a measure of brain amplitude. And as we age, our brain does shrink back a little bit. So the signal that we measure on the top, which is a measurement through bone and through everything, if the brain has gone further away, the signal amplitude, the height of the brain waves will be less. So some of this is a little bit artificial because we've just automatically said we need a height of say 75 to call that deep sleep. And if we don't have 75, even if the waves look the same, we say we can't call that stage 3 sleep or N3 sleep. So some of it is artificial. Some people retain a good sleep, others don't. But naturally, we do spend more time. And then obviously, when we start retiring, we have the ability to have a siesta. And siesta, as you all know, speaking Spanish, comes from the word six. So 6 hours after we've waken up, we get sleepy again. So that's pretty cool. And if you live in a hot climate, having a siesta is a brilliant idea in the afternoon for up to an hour. And it just sort of breaks up that heated day.
Wonderful. So melatonin. Let's hear about melatonin.
So now that we've covered the different sleep stages themselves, you're probably wondering what helps to put you to sleep itself in the first place. So one of the key hormones that aids us to put us to sleep is melatonin. And as it begins to darken outside, your suprachiasmatic nucleus, or SCN, basically sends a signal to your pineal gland, which is in your brain, to increase melatonin production and release. Your SCN is basically just a bunch of cells in your brain that acts as a control center for sleep and arousal. So it receives information about light exposure directly from your eyes and uses it to control behavioral rhythms such as sleep. And this is basically why darkness helps us to fall asleep, as melatonin increases and aids us with sleeping. It's important to understand that it doesn't actually cause sleep, though. It only encourages it by helping us orient ourselves with our circadian rhythm. So as a result, melatonin helps regulate our circadian rhythms, which help us synchronize our sleep-wake cycle with night and day. In doing so, it facilitates a transition to sleep and promotes consistent and quality rest. So moving on to cortisol. Cortisol is another important hormone that helps us sleep, and not helps us, but is involved with sleep, and it's produced by a complex network known as the hypothalamic pituitary adrenal axis, or HPA axis. And cortisol plays an important role in one's stress response, as there's an increased cortisol production in stressful circumstances in order to help trigger instant threat responses in our cells. So this includes having a rapid heart rate, a spike in blood sugar, rapid breathing, and even sharpened senses. Because of this, cortisol can impact sleep, as it follows a circadian rhythm similar to sleep. Every 24 hours, the body enters a period of sleep followed by a waking period, and cortisol also follows a similar pattern. On average, cortisol production is lowest around midnight and peaks an hour after you wake up. In addition to its circadian rhythm, there are also around 15 to 18 pulses of cortisol that are released throughout the day and night, which correspond to the shifts in our sleep cycles as we discussed earlier. So do you want to move on to the next slide? So you're probably wondering how you can find out about your personal sleep cycles and sleep patterns as well. So the Fitbit has become a popular method of tracking sleep behavior and heart rate, and it estimates your sleep stages by combining your movement and heart rate patterns. So no movement for an hour tells the Fitbit you're asleep, along with other signs such as the length of time of your movements are, for example, moving briefly to roll over. And throughout the night, it tracks changes in your heart rate as you progress from light sleep to deep sleep and REM sleep. And the Fitbit tracks changes in your heart rate as you progress from light to deep and REM sleep stages. So I was just wondering, Dr. Gottschalk, do you have any experiences with the Fitbit and how it may help patients in identifying how they are sleeping?
Yes, that's a very pertinent question given the burgeoning use of wearables. And in fact, everyone really could use something like this. The problem with looking at them, there are new iterations coming out every couple of years. And so the validity of some of these things is not proven. There's much more hype than there is accuracy. And for some people, what it does is it then facilitates that absolute angst that they are not performing. So they get performance anxiety with regards to trying to get the best Fitbit outcome. So I would be cautious with these wearables at this time. They can be illustrative in some ways. They're not particularly accurate, but they are getting better. So at this point, if you're interested, that's fine. If you've got a worrying bent through your soul and spirit, not a great idea. So back to you.
So so if you are interested in and if you want to use it as a learning purpose, how's the best way to approach? What's the parts that you find helpful in this on these applications?
Well, it can be used really as a device to identify when you are falling asleep or when you are in bed. Because often what we get with insomnia, we have a device called an actigraph, which really tracks movement. It can be fooled by those who lie in bed like a corpse and don't move at all. But typically, people, when they're not sleeping, they're moving around, and the actigraph will pick up movement. And then when you're asleep, these movements go down. So it gives you a pattern. And this pattern shows you their sleep staging and their cycling. Where the actigraphs are helpful is in people with insomnia. There are many people, when we bring them into the sleep lab and we do a sleep study on them, and they sleep 7 hours complete, yet they say, "Oh, I didn't sleep a wink last night." And you try and show them the data, and they barely believe you. They say, "Well, I didn't sleep at all. I heard everything." And so there's a misperception for some people, and many people with insomnia, they overestimate how much time they are awake, and they underestimate their sleep, because this has become a self-fulfilling behavior. And so that's why we are not that keen on people tracking the sleep too much, other than if there's a rhythm disturbance. And there's some very strange rhythm disturbances where people can't entrain themselves on a 24-hour cycle. That's where these can be very helpful for us. But beyond that, at this point, I'm just not aware of the latest wearable data as to accuracy compared to sleep studies. They're coming out all the time with improvements, but at this point, it's not Madison Avenue yet.
I find just watching any of our webinars or any medical information puts me to sleep really easily, and I can actually fall asleep holding my computer in my hand and on a chair sitting up. And unfortunately, I don't absorb much of the information, but it's a good way of falling asleep for me.
And just as Dr. Gottschalk mentioned, I think it's good to be cautious with these like wearables and Fitbits. But Dr. Kearney wanted me to share his Fitbit data with everybody. So I've just kind of put the two pictures here. So this is what typically it looks like on the phone if you're tracking it. And so I've just highlighted Dr. Kearney's most recent sleep score. And the sleep score is made up of how much time you were asleep, the level of deep and of REM sleep that you're getting, as well as how peaceful or agitated you were during your sleep. So it looks at your resting heart rate compared to your sleeping heart rate, and it comes up with a sleep score out of 100. So if anyone was wondering kind of how that sleep score is created, this is kind of that guide to let you know how the points are kind of calculated.
So Raymond, this is last week's and this last couple of days over here. How would you help interpret that?
You need a sleep doctor. It certainly doesn't look like you know, if that is a valuable representation of your sleep, you're really going to bed at 1 in the morning?
It depends on the day. So this time right now is that with COVID going on, I'm usually getting home at 9 to 10, and then I'm reading and having dinner, and usually falling asleep around that time these days. Yep. Once or twice a week, I have a good night's sleep. And most weekends right now, I'm on the COVID ward. So this is my life right now. I don't feel, and I get up early in the morning. I play some tennis if I can. And it's interesting is that I don't know if it's always totally accurate. I think I get a little bit more sleep than what Fitbit tells me. But
what would be helpful is actually to keep a log, you know, just a little diary at the bedside, and put in what time you actually get into bed, and then just estimate in the morning what time you felt you fell asleep and what time you did wake up. Because certainly from all the categorizations that we have, looking at only one of those days you got more than 5 hours sleep, all the rest are very deficient. So if you want to get your car wash of your brain done properly and not build up tau and amyloid protein, I would look at extending the time for your brain to do its defrag and to do its deep clean. because this is, we start off with 100 billion neurons in our head. And over time, we managed to relegate some of them to the scrap heap of the allostatic response within our bodies. But anything to protect that time. We do know the old adage of early to bed, early to rise, but indicating adequate sleep. You can't keep cutting corners, and you are cutting them fairly tight there. So I would caution you as a respected colleague that you need to protect yourself a little bit from the vagaries of too little sleep. Otherwise, you're going to find you're going to wander around and not know where you are.
Thank you.
So we're just good.
Okay. Oh, sorry.
Go ahead.
Okay, so the next thing that we're going to talk about are some common sleep disorders and treatments associated with them. So if you want to go to the next slide. So the first one that we're going to talk about is insomnia. And this is typically when individuals have difficulty getting enough sleep, difficulty falling asleep at night or staying asleep, as well as waking up throughout the night. And this also includes not feeling refreshed after waking up in the morning or experiencing tiredness or sleepiness throughout the day. So some common causes of insomnia can include stress, anxiety, or depression. And in terms of stress, this can look like concerns about work, school, family, finances, or trauma that may be keeping you up at night. As well as some other common causes can be poor sleeping habits. So having an irregular sleep schedule, napping frequently during the day, using your bed to work or watch TV, or using any screens before bed. This could also include a busy work schedule, so things like jet lag or constantly working different shifts. So morning shifts or evening shifts can also affect your sleep. Even pre-existing medical conditions can be a common cause. So conditions linked to affecting sleep like chronic pain, diabetes, heart disease, and etc. Another common cause is medications. So many prescription drugs can interfere with sleep, such as antidepressants, as well as over-the-counter medications, such as allergy or cold medications. There can also be sleep-related disorders. So disorders like sleep apnea, which can stop your breathing during the night, can cause insomnia, and this is something we'll discuss in the following slides. And as well as changes in activity, like being more or less active during the day, can also lead to insomnia. Okay, so moving on to some treatments for insomnia. This can include changing sleep habits, so having a more consistent sleep schedule or hours of sleep, or addressing any lifestyle changes, like helping treat situations that may be causing stress. There's also cognitive behavioral therapy for insomnia, kind of like what was mentioned earlier on in this webinar. It can help to recognize and maybe change beliefs that affect your sleep and then help you develop some good sleeping habits that will help you sleep at night. Meditation is also an example of something that you can participate in that may help reduce anything related to stress that can contribute to insomnia. And as well, prescribed medication or over-the-counter medications can be used to help treat insomnia as well, more for a short-term use and not regular use, and should definitely be talked about with your doctor before using.
And I just want to mention a great resource to learn more about insomnia, if you're more curious about this particular one, is to look at this book called Insomnia in Adults and Children. It was co-authored by Dr. Gottschalk. It has a lot of lovely resources and information that kind of is related to the webinar today, but is specific to insomnia. And it was kindly made available but free by the Canadian Sleep Society with the following link. So if you're interested, please look into it. I think there's a lot of great resources. And it also goes into the cognitive behavioral therapy we were talking about earlier and gives a lot of practical suggestions as well.
So Raymond, do you want to say anything about the book that you find the parts that people should look at first?
there have been evolutions since then, not so much in the book, of course, because we only did that one series. I think, it's a very quick read. So it's very easy to read the whole thing. But certainly some of the other resources that you've provided for CBT, when we know that that's the basis. The basis of the management and understanding of insomnia is really to free people from the tyranny of needing medication to assist their sleep. And so this is a great book, but it's less valuable now that we have the other aspects of online CBT, free CBT, that needs to be practiced first.
That's a great segue. These are some resources that are actually free to all residents in Ontario, age 16 and over during the pandemic. Obviously, we've known that there's been a sharp spike in anxiety, depression rates, and as a result, the Ontario government has been very kind to provide a free CBT. And these are specific to insomnia, but within the programs themselves, they cover a wide range of concerns, including anxiety, depression, trauma, grief. So if you are interested in looking for like a resource, they're all guided support by professional therapists. So for Ability CBT, you'd be working through 10 modules with support from your therapist. And both of these are really nice because it can be done on your own time. So they give like an estimate of how much time it takes for most people, but it's really up to you how slow or fast you want to get through those modules. And for Mind Beacon, it's almost usually a 12 weeks of therapist guidance to complete a course with readings and activities that are selected by your therapist. And I've added the links below if you're interested in looking. Both of them will have some sort of pop-out that says free to all residents in Ontario. So all you have to do is just click I live in Ontario and you should be able to sign up.
Are these your favorites, Raymond?
These are certainly no, they're not my favorites because to be very frank, I wasn't even aware of these. We've been using therapists and a company called Haleo, Haleo, where they've been charging people, about $50 a session, 5 or 6 sessions for CBT online. We've used the group out in Harvard, the CBT. I've forgotten their label, but there are quite a few others, and there's an online video that's really helpful from a woman out in BC, Christine Corral, Korral, who has done a 1-hour CBT. She's fantastic, and so this is lovely to have this. And I don't know why we weren't given any heads up on this before my colleagues here found this. So this is excellent. This is cutting edge. So thank you for bringing that up.
I also was looking into it and just came across it. I wasn't aware that these were available. And I really like that there's a lot of different programs for different needs. So both of them require like a short assessment that you'll be completing to see if the program is right for you and right for your needs. So feel free to look at those sites if you're interested.
All right, so the next common sleep disorder that we're going to discuss is sleep apnea. And there are 2 different types of sleep apnea. One is obstructive sleep apnea, where the muscles in the back of the throat relax. And these muscles essentially support different structures in your mouth. So when they do relax, your airway will then narrow and close, making it difficult to breathe. You're not getting enough air, and this can also lower your oxygen levels. Your brain will try to send signals to your muscles to either snort, choke, or gasp, which will awaken you briefly and kind of interrupt your sleep. Then there is also central sleep apnea that occurs when the brain fails to send signals to your breathing muscles. And so you can also awaken with shortness of breath or have difficulty breathing, which will wake you up or interrupt your sleep. There is also complex sleep apnea, which is when both obstructive and central sleep apnea can occur at the same time. And then some common symptoms associated with sleep apnea will include things like loud snoring, episodes where you stop breathing while sleeping, gasping for air while sleeping, waking with a dry mouth, morning headache, or difficulty paying attention while you are awake. And moving on to some treatment associated with sleep apnea. First, it's always recommended to make some lifestyle changes. So, any activities or habits that include things like losing weight or even quitting smoking. There are also some different therapies for sleep apnea, like CPAP, which is a machine that delivers air pressure through a mask while you sleep. There are also certain oral appliances that you can wear that are designed to keep your throat open, which can also help relieve snoring. There's also treatment for associated medical problems. Sleep apnea can be related to other problems such as neuromuscular disorders. So treating for that may also help with the sleep apnea. There are also supplemental oxygen devices, which can help deliver oxygen to your lungs. And then there's also an adaptive servo ventilation device, which is a device that learns your normal breathing pattern and then helps you maintain you sleep. So if it senses any changes, it'll bring it back to your normal breathing pattern. Lastly, there's also surgery that can be a treatment option. So things like tissue removal, tissue shrinkage, jaw repositioning, implants, nerve stimulation, or a tracheostomy. And when moving on, another common sleep disorder.
You go back to these devices, sleep apnea. So Raymond, other patients love it or they hate it, it seems like. I don't see too many people in the middle of this over there. And I know we're going to talk a little bit about that, but I see so many people that just struggle with their machines. And do you have any pros here about that?
It's much easier to sleep without a device on your face than with one. So, typically the people who do well with CPAP are those who are quite symptomatic. And we're currently doing a study where we're looking at people who have a naturally good brainwave pattern of sleep. They have severe sleep apnea, but they're not apparently impacted by it. And we're trying to figure out, are there subgroups of people who actually are more impacted by the apnea, then they are more likely to be adherent to therapy. So the folks who adhere to therapy are those where they really care about their spouse being with them in the bed, and it becomes a big issue for them. So they will put up with the inconvenience of a CPAP, or in those who actually feel much better. The pattern of use of CPAP use is really established within the first night or two. And if there's enough support, what we know in the sleep literature is that the more support there is, the more people will be able to adhere. And the problem is that the less funding there is to purchase machines, where companies who would normally give that type of support, if they're not able to do that anymore, that's going to result in a relegation of a lot of these machines to collecting dust in the cupboard. So a lot of this is dependent on the home care company that provides the unit, how they fit the mask, the type of pressure that you have, the type of machine that you have. All of these things make a difference, whether you can even breathe through your nose. And so certainly we know that adherence with CPAP can be anywhere between 20 and 60%, depending on who's given it. My joke is obviously the analogy, if you're a hammer, everything is a nail. And for years, it has been felt that the sleep community just looked at everyone as sleep apnea, take a CPAP and off you go. And that doesn't work. There needs to be buy-in from the patient. They need to understand why they're using it. They need to understand, the net negative of a device that you're strapping to your face every night. And so, it's much more complex than the oversimplification that we often use. It just blows open your airway and that's it, which is in fact how it works. But there's a lot of motivation and do people feel confident that they can use it? And if you start with some self-efficacy, I feel that I can do this. And I ask my patients, do you think this is something you can do? And almost guaranteed if they say, absolutely, you know that you're going to get a winner. And those who are sort of, they're perseverating a little bit, they're on the fence and they say, not that sure. Yeah. it's you know that they're going to be a tougher sell.
Thank you.
All right, so the next common sleep disorder that we're going to be talking about is restless leg syndrome, also known as RLS. This is a condition that causes the uncontrollable urge to move your legs, which can be due to an uncomfortable sensation. This sensation is typically hard to describe by some people, but it has often been described as a crawling, creeping, pulling, throbbing, aching, itching, or electric type of sensation. And some of the common symptoms that are associated with RLS is, like I mentioned, the urge to move your legs. These sensations typically begin after sitting or lying down. There's also temporary relief with movements, as well as worsening symptoms in the evening. And so you often get nighttime leg twitching as well. So some of the treatments associated with RLS, again, there are some lifestyle changes or even home remedies that can be used to help with this. So things such as baths and massages, or applying warm and cool packs, as well as practicing some good sleep habits or exercising regularly, and even avoiding caffeine can help reduce or help treat restless leg syndrome. But there are also prescription medications that can help reduce the restlessness in your legs. So things like muscle relaxants or sleep medications, they don't eliminate the leg sensations, but they can cause drowsiness that can help sleep better at night. Opioids are often or not often used, but can also be used, such as narcotic medications to relieve mild to severe symptoms, however, used at smaller doses. And there are also medications that can increase dopamine in the brain that affect the levels of that chemical messenger in your brain to again help to reduce that restlessness in your legs.
So Raymond, I've seen a lot of people struggle with restless legs. I always worry about that opioid. I'm not quite sure where that fits in. What advice to get to individuals who are struggling with restless legs? How do you help them?
Well, restless legs can be a terrible condition. And so I don't know if you've ever had a shot of stelazine or anything like that, and you get that acute dystonic type feeling. It's a writhing sensation for some people. They cannot get to sleep. They cannot settle the legs down. And so there's a hierarchy of treatment. The things that can make it worse are antidepressants, the SSRIs, the SNRIs, anything that increases serotonin and reduces dopamine can cause that. The drug therapies that we use are things like pregabalin or gabapentin. They interfere with glutamate production. Glutamate is part of this. Adenosine is part of it. So the adenosine blockers, caffeine, and theophylline and chocolate, those can make it worse. Whereas adenosine itself makes it better. And so I don't know when last you used dipyrimidol. That apparently works on the adenosine receptor and can be very effective, but I can't get it. I'm looking to see if I can find it. Opioids are incredibly effective. And there's always obviously that concern, can people become addicted to the opioids? Of course they can. In restless legs, interestingly, you need a lower dose. And probably the most effective therapy for the restless legs is methadone, 5 to 10 milligrams, whereas when you start going 30, 40 milligrams, you start suppressing breathing. So it is very tricky. So the way I approach it is to make sure the iron level is normal. Iron is a cofactor in dopamine production. The brain is like Fort Knox. You can't get anything into it, and you can't get anything out of it. Very much the same with iron. So you check the ferritin, you want it greater than 100. Our laboratory normals are between 10 and 300. And you tell me in biology how you can get a 30-fold difference between the upper and lower level and call that a normal range. It's ludicrous. So we find that iron deficiency is an incredibly common cause. And in people who have high ferritin values because of inflammation, you need to give them a trial of iron therapy. So it's getting rid of the antidepressants. It's getting rid of the caffeine as best you can, considering the dopamine agonists, but the problem with the dopamine agonists is that they have their own problems. The things like ropinirole and pramipexole, after a while they stop working and they can make it worse. So it is a very tough condition to treat. So sorry, that's a long-winded way of saying this is a really evil beast out there.
Thank you.
All right. And we'll just be talking for a few slides about cardiovascular health and sleep apnea, and specifically we'll be talking about the efficacy of the CPAP machine. Just before I get into that, we're going to be talking about how sleep apnea would be diagnosed at a sleep clinic. And I've provided a bit of an overview here. Thank you to Dr. Gottschalk for providing his slides. But I think maybe the best would be just asking the specialist himself. Dr. Gottschalk, do you want to talk a little bit about what the experience is like for patients when they're going through a sleep study?
Yes. So what we measure, it's called polysomnography. Why poly, many, somnography, many things while you're asleep. So what we measure brainwave activity. So you get a lot of electrodes on the scalp. It measures eye movements to identify when you're going into dreaming sleep. It measures breathing, and as you can see, there's a little breathing tube in the nose. We have two types of breathing device. One is called a thermistor, and the other one is a nasal pressure transducer. Then we have the chin signal to see when people are going into REM sleep. It also identifies when they're grinding. The EKG, a 3-lead EKG. There's movement of the chest, movement of the tummy, and then there are leg electrodes to show leg movement. So you get a lot of information, and an oximeter, a little thing on his finger you can see, all connected to this blue box, which is called the head box, which then relays off to a computer. And when it's analyzed, what people are looking at, they're looking at the sleep stages, as you talked about, how much deep sleep, how many awakenings are they getting. They're looking at leg movements for restless legs and periodic movements. They're looking at breathing to see how much you're stopping breathing. They're looking at the heart rate response and grinding and any abnormal brainwave activity. So there's a lot to see in a sleep study. And of course, it's not exactly the most conducive to a perfect sleep, but people they typically tolerate it quite well, depending on the expertise of the technician who's putting on all of these electrodes. And the whole setup to put that stuff on is about sort of 30 to 45 minutes. And then they come into the sleep clinic, they sleep overnight, and the following morning they're ushered out at 6 in the morning. And a couple of days later, the results are analyzed, they're reviewed and called scored. So the technician looks at all of this information and then comes up with a tabular output that then gets interpreted by a physician who also looks at snapshots of the sleep. And we get those examples where we can see all of the channels, including the oxygen, heart rate, breathing, and everything aligned with each other. So it's quite a fabulous, it's much more complicated than those cardiology guys who mess around with EKGs and things, but and it's much more fun too. That's what's entailed in the sleep study, and we try and get back to patients within a couple of weeks to review those results and decide on therapy. And the big therapy decision is really it's evolving now. We don't just go with numbers. If you stop breathing for 10 seconds, that's called an apnea. If you stop breathing for 2 minutes, that's called an apnea. And if you stop breathing for 2 minutes, your oxygen level is going to go down to 50%. You stop breathing for 10 seconds, it may not drop below 90. But yet they are both counted as one event. So clearly, what we've used as our anchor to define the severity of apnea should really be modified by how much oxygen change there is and what type of other comorbid issues there are. An 18-year-old with a little bit of apnea is not a big deal. A 58-year-old with severe cardiac disease with a similar amount of apnea may prompt the need for therapy, especially if the oxygen level goes down.
Now, it's interesting, working with one of our nurses who is a young lady who is trying to get her weight down, has hypertension, and has a body mass index in the mid-30 range. And someone told her to get a sleep study because she had difficult to control hypertension. She didn't have any symptoms, and it comes back that she has quite severe apnea. I don't know the actual details right now, and I was kind of surprised to learn that she really didn't have any, she slept through the night. Her spouse didn't notice anything. She had restful sleep, and yet she has severe sleep apnea on the study, and she has severe hypertension. What's your thoughts about that?
Well, what we recognize, anyone who's on 3 drugs or more for hypertension, they're almost a slam dunk for sleep apnea. Now, the sad news about treatment of sleep apnea, very often the hypertension does improve, but not it doesn't have to be a lot. On average, the studies have shown that treatment with CPAP may drop blood pressure by 2 or 3 millimeters of mercury. However, we all have subgroups, and I've seen this repeatedly, where you can get someone who gets a normalization of their blood pressure. And it's not difficult to see if you understand mechanistically, when you stop breathing and you're sucking a negative Mueller maneuver in your chest, and you suddenly stop and wake up and burst, and your pulse rate shoots up 20 to 30 beats extra, that is going to be associated with a surge in blood pressure. And typically, blood pressure drops 10 to 20% during sleep. And in people with sleep apnea, you don't get that reversal. So there's really no downtime. The idling of the engine at night is impeded. So it's basically running full tilt, but now you're making it oxygen deprived as well. So not difficult to see in those circumstances that you can develop a super hyperadrenergic, increased catecholamine state where your blood pressure will be up, and you relieve that. You get a much more massive response to your blood pressure lowering than you do in the average obese person with sleep apnea and sort of marginal hypertension.
So what's interesting is that sometimes we see doing a 24-hour blood pressure machine, so failure to dip at night or rise at nighttime or bradycardia at nighttime make me think of sleep apnea, getting acidotic. And there's actually some data that treating blood pressure at nighttime has better outcome compared to measuring or treating blood pressure during the daytime. Do you have any thoughts about when to treat high blood pressure?
Yeah, all the time. So the reality is that certainly taking blood pressure medication at night for most people is probably not a big issue. But because you're getting a blood pressure drop anyway, if they do get up at night, you sometimes get the odd patient complaining of hypotension. They get up, they go and urinate, have a vagal attack, and fall over, which is not really what we want. But it's really trying to control what may be causing that. And a lot of people have had the lack of dipping. If you actually ask them, well, I slept so poorly that night, that's not a lack of dipping. That's a lack of sleep, and you won't dip. So they need to be asked whether they did sleep when that thing was done. But certainly when we look at chronotherapy, which is guided therapy to maximally assist, people are meant to take aspirin at night rather than in the morning because of platelet aggregation early in the morning. They're meant to take antihypertensives more at night than in the morning because it's sort of better, the cholesterol drugs. But all of those may affect the sleep as well. And I have some people who are taking the HMG CRA reductase inhibitors at night, and they say, I can't sleep. They take it in the morning, they say, I sleep much better. So unfortunately, there's a trade-off every which way we look. But certainly controlling the aspects of sleep, whether it is periodic movement activity, not restless legs itself. Restless legs stops you getting to sleep, but it's that leg movement activity throughout the night that can be associated with blood pressure elevation. You won't pick that up on history. You'll pick that up on the sleep study. And sometimes we see dramatic changes in their pulse rate with those leg kicks. So there are subgroups of patients whose hypertension may be related to periodic movement activity rather than sleep apnea. And the two feed into each other because you destabilize the sleep. And if you're oscillating in and out of sleep, you're going to have sleep apnea anyway. It's a long-winded way of just saying this is more complex than meets the eye and unfortunately needs a little bit longer discussion time than we have available.
Sure. If someone loses 30 pounds, how much improvement will they see in their sleep apnea?
Depends where they're starting. But typically every 1% body weight you lose 2% sleep apnea. You don't get that in the bank at the moment, okay? That's a big yield.
Go ahead.
Yeah, just going along that vein, we know that obstructive sleep apnea is a risk factor for cardiac disease, stroke, and cardiac arrhythmias. And then one of the biggest or actually the largest randomized controlled trial called Sleep Apnea Cardiovascular Endpoints, also called SAVE, published in 2016. Had some very interesting results. I'll let Dr. Gottschalk also talk about it as well. But essentially, they recruited almost 2,700 patients, either who had heart or circulatory disease, and half of them were given the CPAP machine and half of them were just given usual care. And they found that patients who received the CPAP had reduced snoring, better daytime function, mood, and quality of life. But unfortunately, the mortality rates between the two groups didn't differ significantly. And I think Dr. Gottschalk, I think this came as a very big surprise. I was looking at the literature and I think it came as a surprise because up until then, a lot of the literature was really pointing to CPAP really having some good benefits. Do you have any thoughts?
Yes, it really wasn't a surprise when you read the data because they used it on average for 3.25 hours or 3.5 hours, the typical nighttime sleep of 8 hours. So you half treating, and you're treating the first half of the night. And apnea is worse in the second half of the night when you're in more dreaming sleep, your REM sleep. So actually making any inference from this is really baseless. Also, the population that they chose, a large portion of this was from rural China. And I'm not impugning rural China's medical system, other than these were not people who had actually been assessed in a sleep laboratory. So we really don't know, what type of input they were given. I think one of the difficulties with this, and the obviously the lead issue with it, is the hours of use, and secondly, you're looking at progression of disease. We're looking at trying to prevent disease. So once you've got established cardiac disease, dealing with the progression is a very different aspect to trying to prevent it. And I think that's where the longer studies, which will not be completed in my lifetime because it's too difficult to do, but taking people who have no cardiac disease and looking at them, because it's really not ethical not to treat someone with severe sleep apnea if they were somnolent. And what we're looking at now, people who have sleep apnea who are sleepy have a much worse cardiac output than those who are not sleepy. So there are different populations of apnea, even though they've got the same AHI. And because we're using that stupid AHI on its own without any qualifier, we are left not really knowing how severe these people are. And so you'll see all of those limitations in these studies.
Sorry for interrupting. It seems like the meeting's going to be ending again, so let's just take a quick break and then I'll reset the meeting links. So just take like a quick 2-minute break and then we'll rejoin the meeting so we have an extra 1 hour again for the meeting. So I'm going to end it and
Wonderful.
then we'll rejoin. So everyone on YouTube can take a quick 2-minute break.
I look forward to it. See you guys in 2 minutes. I'm learning so much.
Yes, this is really informative. And sorry again for
Oh no, listen,
for
this
That's
is
all the
okay. That's
technical
okay.
issues.
hey. We make ours too long anyway, so we'll have to make Are there many people on YouTube, Jerry?
Yeah, I think we have I think we're around 22 right now, and there has been no questions so far. I'm monitoring the chat, but I think we peaked at around 26, and right now we have around 22.
Sure.
I'm sure this will get a lot of views afterwards. That's all right.
how many more slides we have left to go through there, Hannah?
We are on. We are on 32.
And we have like 50 something.
And yeah, we have 50 something, I think.
Are we doing a meditation?
60? Yeah.
Are we doing a meditation as well?
Yeah, I was thinking of doing a meditation, but it depends. I think depending on time. We can
Yeah.
always link them a
Sure.
meditation as well. Yeah.
So we can do a separate one later. We'll just do a separate
Yeah.
one. Yeah, sure.
Yeah.
All right.
Sorry, sir.
Are we ready to relaunch again?
Yep, whenever you guys are ready.
Is everybody
All
good?
right.
This is fantastic. Lots to learn. I'm learning so much. Whenever you count us in there, Jerry.
All right, welcome back, YouTube. For a quick 2-minute break, sorry about it again, and apologies to Dr. Kearney, Dr. Gottschalk, and everyone here, but we're ready to roll.
You know, this is fascinating. I remember when this study came out, because I was told for years that sleep apnea was a bad thing, that we need to use these devices and things, and I really appreciate Dr. Gottschalk's opinion on this. Is that so? To me, what I'm learning is that people that are very symptomatic, have severe sleep apnea, would probably benefit the most. And if you're going to use it, get some people who can show you how to use it and learn how to use it and use it properly. And what else do you want to say about this? Because it's important. And also, too, is that if you're not overly symptomatic, maybe you don't need the device. Is that a fair thing too as well, or not?
I would be cautious. Again, if we go with a number, what we know is that low oxygen level is dangerous. And I've had people who've dropped it. We know that Varen Sommers from Mayo has basically stated that if you have an oxygen level 10% below 90% of saturation, oxygen saturation, or you drop below 78%, you've got a 4 or 5-fold increased risk of sudden death through arrhythmia. So certainly if you have someone who has mild apnea, but they have severe drops in oxygen, you are going to treat them. Hypoxia, low oxygen level is dangerous. That is the rider on this thing. If I have someone who's got a lot of apnea, stop breathing 50 times an hour, but their oxygen levels are good, I'll push them for weight loss. If I have someone who stops breathing 9 times an hour and their oxygen levels drop down into the 50s and 60s, I'm absolutely going to treat them. So it really is based, and yes, some people have severe apnea and they don't have symptoms. And that's one of the big studies that is being done now out of Toronto, and a fellow called Alan Pack is looking at this to see, is there a discernible difference in these people who don't feel bad, they are not somnolent, yet they have severe drops in oxygen. I think it's almost medically indefensible not to treat someone who is severely hypoxic. You know that they are doing damage. You know that if you have low oxygen levels, you are damaging things. So, anyone who's had a near drowning or a hypoxic episode or, cardiac arrest, you see the results. And we have a certain panoply of brain, as I said, 100 billion neurons, and you blast a whole bunch of them out. There comes a point at which there's irrevocable change and you start losing your function as a bright human. So beware of the low oxygen.
It's kind of interesting you bring up the issue about brain injury and what we're learning from all diseases. Concussion was a great movie that showed that getting your head banged younger in life leads to more Alzheimer's disease later in life. And my disease model is atrial fibrillation, where you have an irregular heartbeat that leads to more brain damage, more stroke, and more dementia. So you can see this: protect your brain. So I'm gonna have to sleep better to protect my brain, so I can do better. So I'm learning. Any study asks more questions than answers, and we're learning. And I think one of the things that people found challenging about COVID is that we've learned so much, and information changes, and we adapt to that. Health professionals do a good job of that. You as individuals, you need to learn new information and adapt to as well. So let's hear some more.
Absolutely.
Perfect. So at this point with this study, as Dr. mentioned, because they were only using the CPAP, I think on average it was 3.3 hours. It's hard to say really with this study whether the CPAP was effective So if you are wondering, should I still consider and or use a CPAP machine? Our answer would be not to discount CPAP yet. We look at previous studies done. We know that patients with heart failure were 4 times more likely to die if they were non-adherent to CPAP. So if they weren't following through and using the CPAP machine throughout the night, and twice more likely to die if apnea was not treated. And you can see that in this graph over here as well. So patients who are using the CPAP machine for at least 6 hours a night compared to patients who were using the CPAP machine for 3.5 hours, which is similar to the individuals in the SAVE trial, the patients were 4 times more likely to die. So we know that cardiovascular health and using the CPAP machine for sleep apnea is still protective. And also, I think this is something that Dr. Gottschalk mentioned earlier, but it also has to do with the quality of your sleep. Earlier, I mentioned the SAVE trial. We know that it reduced snoring and patients reported higher quality of sleep as well. So it's important to consider all those factors when you're thinking about using the CPAP. And Dr. Gottschalk, go ahead if you have anything additional.
What we do find is that with long-standing snoring, you start developing swelling of the airway. You're vibrating the tissues. I mean, if I keep on smacking your hand, it gets red and gets swollen. So if you keep on slapping the back of your throat, it's going to become swollen. So snoring begets apnea. And when you put someone on a CPAP and you control that and the airway swelling goes down, they can get a night or two before the swelling comes back. So some people are able to use it and skip a night and find, they don't start snoring like a stentorium, from old Roman times. But people who use it for 3 or 4 hours a night, they may get enough coverage that they don't snore. And part of that enhances their quality of sleep, but they're not getting the full benefit. There is a direct correlation with the hours of use of CPAP and outcomes that are improved. And quality of life goes up at the end of 6 hours, 6.5 hours. You see a marked increase in quality of life, which is really important.
Thank you.
All right, so now that we've covered the indispensable role of sleep in maintaining our health, as well as the extremely detrimental effects of insomnia, it's no wonder that a lot of people turn to herbal supplements, over-the-counters, as well as prescription medications in order to try to help them with these conditions. And it can obviously certainly be overwhelming given the vast array of what's available, so we hope to at least provide somewhat of an overview as to what's out there. Yeah, so as we know, the beauty of cutting-edge technology every year blesses us with new chemical compounds that most of the time greatly improve our health. So with how many there are coming out, it's kind of an exercise in futility to go into the nitty-gritty of each, but I wanted to point out some general trends. So like Dr. G mentioned earlier, a lot of antidepressants can either exacerbate or help with insomnia. Some of the ones here, like doxepin, which is a tricyclic antidepressant, happens to help us stay asleep. A couple other categories, you might be familiar with benzodiazepines. This can include things like temazepam as well as estazolam. These are part of a class of drugs that we can call them downers because they slow down your body's propensity to be excited and aroused, kind of dampens your fight or flight response, and instead calms you down. However, it can certainly make for a specifically dangerous combo if combined with alcohol or overdosed upon. One trend I want to point out is there is a marked difference between medications that help you fall asleep versus staying asleep, which might initially seem trivial at first, but a big part of insomnia is the inability to stay asleep when you've fallen asleep. So sometimes you'll wake up in the middle of the night. It's a common occurrence for a lot of people, but we often don't remember the fact that we've woken up because it's so short. It's not very significant towards the overall quality of our sleep. But we find that in some people, especially as they age, this can become significantly more problematic because they might find themselves waking up more often, more times throughout the night, and each time finding it progressively more difficult to return to sleep. So then in any of these cases, a lot of these drugs can certainly be very helpful in terms of helping to tackle insomnia. But as with a lot of medications, there is a risk of side effects such as dependence. So we know that once your body is used to having these external compounds inside, it might have a more difficult time once you don't have those medications. And not only that, it might sometimes build up tolerance, in which case it'll require more and more of the same medication to achieve the same amount of results. And some other common side effects could include anything from headaches, nausea, alterations in appetite. At the end of the day, it's really hard to pinpoint what medications are most appropriate just based on how effective they are. We have a lot of research and statistics on seeing how effective things are, how efficacious they are. But a lot of it does come down to, I guess, personal patient values. So you can imagine that for some people, nausea is a huge deal breaker, whereas for others, they might be willing to put up with it. Just like an athlete might be more concerned with return to sport versus things like prices of therapy might be more concerning to other people. All right. Next slide, please. Yeah, so there's also a boundless array of herbal supplements and over-the-counters that people can actually take on their own to help with insomnia. And melatonin is one of the most commonly heard of. So as we've covered before, it does regulate our circadian rhythm and is deeply associated with dreaming. It is naturally produced by the body, and we can take it also as an external supplement. This being said, I'm not trying to advocate for or against the fact just because it is naturally produced. After all, our body does produce a lot of natural things, but if we take too much, it's certainly not good for us. So melatonin regulates the circadian rhythm. As you secrete more and more of it towards bedtime, it kind of slows down your body and prepares you to go to sleep. And it is secreted, as we know, by the pineal gland, nestled right there, kind of on the underbelly of our brain. I found it super interesting because a lot of ancient cultures actually associated the third eye with their relatively primitive understanding of neuroanatomy and linked that towards the pineal gland, which we know secretes melatonin associated with dreaming, and they happen to link it with other states of consciousness as well. So, it's not necessarily the same as many of the other medications we might be familiar to taking on a regular basis, because melatonin is actually available over the counter. And because of this, it's not regulated in the same manner as prescription drugs in terms of availability and dosage and standardization. And next slide, please. So we've covered a couple of the effects of melatonin and how exactly it helps us fall asleep, both when produced naturally or taken as a supplement. But there are, in fact, some side effects as well. A commonly cited one is people report that when they take melatonin, they experience very vivid and very subjectively long-lasting dreams. And we know that dreams actually occur in this period of sleep called REM. And everyone dreams every single night, but we seldom remember it unless we really set an intention to do so. But the interesting thing is when you actually wake up directly from REM sleep, you're actually a lot more likely to remember your dreams as opposed to cycling through the non-REM periods of sleep and waking up. So one of the theories of this behind the mechanism of how this happens is that melatonin actually promotes deep sleep, so non-REM sleep, especially towards the earlier phases of the night when you've initially taken the supplement. And then in order to compensate, your body actually increases the proportion of rapid eye movement sleep towards the later phases of the night. Therefore, it increases the continuity of those REM phases and can potentially increase the probability that you wake up in the middle of one, and therefore make it seem that you're having much more vivid dreams. The exact mechanisms of these are still not empirically verified, though. This being said, we know that melatonin levels are affected by light. You can imagine how this makes a lot of sense in the natural world. The sun comes up, we don't need melatonin, we want to be up and about, going about, on with our day. And as the sun sets, that's kind of nature's way of telling us it's time to start winding down, go to sleep. Enter the 21st century, that's not so much the case anymore. Our cities are very bright even at night, especially with our screens jammed right up in our faces. This is where you might have heard of things like blue light filters. If you're like me, it's just that weird setting in your phone that you kind of ignore when it prompts you. But the concept of this is just blue light is supposed to be very similar to that which we see during the daytime emitted by the sun and as the rays travel through our atmosphere, giving the illusion of the blue sky. And so, therefore, by reducing the amount of blue light coming from our screens, giving it that little bit of an orangey tinge, that's supposed to apparently reduce the effect of blue light messing up our natural circadian rhythm. All right, and melatonin, it used to be sourced from animals, but now we have many ways of making it synthetically. And interestingly, the American Academy for Sleep actually doesn't state that melatonin, it states that there's not compelling evidence that melatonin assists with insomnia, but that it can in many cases help with jet lag. So this is interesting because it might suggest that with jet lag, it's often healthy people who are simply traveling. So it might be that melatonin can help us adjust our circadian rhythm. But in the case of insomnia, there's often underlying causes which melatonin alone cannot address, and therefore might not be effective in overall treating. So that actually pretty much wraps up this section on melatonin as well as other supplements and medications. But I just thought of something which I was kind of reminded when Dr. G pointed out Dr. Kernu's shirt that looks like a weed shirt. And that's this concept of a lot of people self-medicating using substances such as alcohol or marijuana to help themselves fall asleep. If you're well acquainted with either of these substances, you might know what I'm talking about because it does put you in a very relaxed, sedated state. The interesting thing with these two is that both THC, the active compound in marijuana, as well as alcohol, have been shown to suppress the amount of REM sleep that we get. So even though we might find that we're getting knocked out a lot more easy, it might be that the quality of sleep is impacted. So it's actually a bit counterproductive. And because REM sleep is so important to us, it's our way, a lot of people think that it's the way for our brain to regulate emotions, integrate experiences, and solidify learning. When we actually miss out on REM sleep on a certain night, our brain is so alerted to this that it actually tries to compensate later in the night or even the next night when you fall asleep by having more REM sleep, and we call that REM rebound. So yeah, just a brief primer. I'm pretty sure Dr. G has more expertise in this field of self-medicating, but I just thought it was pretty fascinating because I saw there was this one case study. I don't know if it's substantiated by the broader literature, but there was someone who regularly used heavy doses of marijuana before sleeping, and he was so REM deprived that he started having hallucinations during the day, kind of inducing a delirium-like state, which is really interesting because it shows that there is somewhat of a difference between simply being sedated and getting quality sleep. So if anyone wants to add on to that.
So if you just back one slide here. So this is everybody always asks. Go back one slide there if I can. The drugs. So basically, there's tryptophan out there. There's melatonin. You can't get the proper pure things. It's a hormone. We had the Z drugs that are associated with falls, dementia, somnolence. We're supposed to use drugs for short periods of time. Use benzodiazepines if you have an anxiety state. Use antidepressants for depression. People sometimes use antipsychotics, but if you're not psychotic, you shouldn't be on antipsychotics. So I think in general, we've done more harm with our sleep aids than a benefit. But saying that, there are some pros in there. So I'm going to ask the expert here is that when do you use medications? That's our initial approach, as you point out, is cognitive behavior therapy, treating some of we have to relearn how to sleep better. But people are always asking for medications from Benadryl to whatever. How do you put this into perspective?
I think that the general rule is try and avoid benzodiazepines. Anything that ends in PAM shouldn't be used. The Z drugs, certainly we have zolpidem and we have zopiclone. We don't have Zaleplon here anymore. Zaleplon was the old Starnock brought in by Servier, and because Health Canada did something with them, they pulled it out of the market here. But zolpidem is much more specific on one subunit of the benzodiazepine GABA complex. So it tends to be very sleep promotive, but it also then increases your risk of abnormal behavior, sleepwalking, and a whole lot of other things that can go with the automatic behavior where you actually are partially asleep and you start acting out behaviors. The doxepin is a tricyclic, but at 3 or 6 milligrams, it doesn't have any serotonergic activity. It has very little tricyclic, no antihistamine. At 300 milligrams, it's a great antidepressant. At 3 milligrams, it is very sleep promoting. So it is the only drug that we can use for those over 65 for maintenance insomnia. It doesn't put you to sleep, but it basically reduces the rise in histamine in the brain, which appears to be influencing your sleep continuity. Lemborexant is a new formulation of what we call the DORA drugs, DORA, dual orexin receptor antagonists. These are drugs that interfere with orexin. Orexin is like the conductor of an orchestra. Okay, the orexin really signals to all of the other neurochemicals to keep you awake. When you are deficient in orexin, you have a condition called narcolepsy. So what they're doing here is they're inducing a sleepy state by reducing orexin activity at night alone. And obviously that sounds a bit alarming, but the benefits for people have been quite remarkable so far, with very little suppression of breathing. So this is the trade name of this is Dayvigo, Dayvigo, and it does help with both sleep onset and sleep maintenance, and there's no carryover. All of the PAMs can carry over during the day, cognitive impairment, and that's increasing risk of falling, but insomnia will increase your risk of falling. So these are, you can run yourself ragged trying to find the right approach. So the approach here is one, treat the underlying condition. Okay, and the underlying condition is not insomnia. Insomnia is the little innocent guy with the glasses who gets beaten up in, when the crowd runs over him. And so what we need to recognize here is that drugs should be used down the line. You go through the behavioral modifications, you go through the drug list, you treat the pain, you treat the anxiety, you treat the depression. And if they are depressed, you use an antidepressant that is sleep promoting rather than one that is alerting. And, there are many mechanistic things where if there's a lot of pain, you want to look at the pain medications that cause alerting. Opioids worsen sleep. They don't put you to sleep. They may reduce your breathing at high rates, but they don't make you somnolent and keep your sleep steady. So the take-home message is this needs to be done carefully with all of the behavioral modifications, fix up the other things that you can fix up, and then at the end of the day, figure out what are the patient who is sitting in front of you, recognize them for the distress that they have, and provide appropriate supportive therapy, whether it's prescription or not, detailing their complaint about whether it's maintenance insomnia or initial insomnia. So my go-to at this point is the lemborexant, because there's no addiction. You can't get hooked on it. It's expensive. It's new on the market. But the current press is quite good. The zolpidem has been out a long time. That's Ambien in the US. Sleepwalking, sleep behaviors are associated with it, and less hangover. Zopiclone, there's hangover in the morning. The Z drugs are better than the PAMs, but you're better off with none of them. So I'm sorry, that's the take-home message.
Thank you. So some people use tryptophan, melatonin. If someone wants to use melatonin and they're not jet lag, is there any role for that at all?
Probably not, unless you're melatonin deficient. It's good for shift work if you take it in the morning when your body's melatonin levels are zero. Now, some people will have melatonin suppression because of the beta blockers you give them, because that interferes with the suprachiasmatic nucleus, which then fires up sympathetic stimulation to the pineal. So when you block that, you can reduce the melatonin levels. So on beta blockers, I sometimes give people a trial of low-dose melatonin. High dose does a whole lot of things that we're not even sure what's going on. So 1 milligram, half milligram is sufficient. For changing your phase shift, if you're trying to shift someone, it acts like a magnet. You take it 5 or 6 hours before you want them to go to bed. If they keep delaying their bedtime, or after a night shift, they take it first thing in the morning when they're getting into bed. That's where it can be effective. But generally, the results are generally not enthusiastic. Tryptophan is a precursor for serotonin, melatonin. Any precursor sounds good, on the press that it's given. There's some studies looking in kids that appear to reduce their parasomnias, the sleepwalking and sleep terrors. but the data is just not clean. It's not recommended as a frontline treatment. So a lot of the over-the-counter things, you're just giving yourself expensive urine. They don't work.
Wonderful.
All right, so I think we've reached the last section and we'll be talking about how we can sleep better.
Alrighty, so I'll be starting off by talking a little bit about sunlight and sleep and how sunlight can improve your sleep quality. So a common question is, can natural sunlight help sleep problems and improve your quality of sleep? And the short answer to that question is 100% yes, because direct sunlight exposure, especially when it's early in the morning, means that you sleep more at night and you can take fewer naps during the day. So that just improves your sleep quality overall. And so a question you may have is, how much sun should I be getting? And generally from the literature, we see 30 minutes to an hour sun exposure leads to significantly less sleep problems. Of course, you're always welcome to get more sleep or more sunlight and spend more time outside. And what I always say is try to make it fun for yourself, instead of seeing it as a chore, like, oh my gosh, I have to go outside for half an hour or however much time today. Try to make it fun. You can make it outdoor time or make it social time, of course, with social distancing, if you're not vaccinated and everything. But you can also walk the dog. If you have other pets, if you have a cat, I don't know if you probably don't walk the cat, but you can just bring your cat outside with you if you want to. But the big takeaway is to make it your time. So the time that you spend on yourself. So yeah, that's just a brief introduction to sunlight and sleep. And on the next slide, we'll talk a little bit about why sunlight affects sleep in the first place. So the thing to understand is that when you're exposed to solely natural light, that leads to your circadian rhythm being synchronized with the sun rising and the sun setting. So you may be wondering what your circadian rhythm is. An analogy is that it's like a 24-hour internal clock. So it's your body's own way of telling the time almost, and it regulates sleep. So it makes sense that when you are waking up when the sun rises and going to sleep when the sun sets, that your circadian rhythm is synchronized with the natural light outside, and that helps you sleep better. So when you get sun first thing in the morning, that also causes your sleep schedule to be pushed earlier, which is in general better. And you may have noticed this in your own personal lives as well. For me, if I decide to sleep in on a weekend and I sleep until like 11 a.m. or 12 p.m., I feel really groggy throughout the day. I always think that I'm going to be super energized because I slept so much. But in reality, it's like it throws your body kind of out of schedule almost. And you notice that throughout the day when you're doing your tasks or going about your day. And then this kind of brings our conversation to electronics and how that can affect sleep. So electronics emit artificial light. We've kind of talked a little bit about this in the presentation. So it's not the same thing as natural light. And because of this artificial light, that leads to a misaligned circadian rhythm. And that can push your sleep schedule out of whack. So what we mean by this is if you've ever noticed, if you check your phone before you go to bed. I sometimes check my phone before I go to bed when I'm setting my alarm, for example, and then I get distracted. And you spend like another half an hour or an hour on your phone. And then you find it's really hard to go to sleep right after that because of the light that was emitted from your devices, your electronic devices. So that's how we don't recommend, that's why we don't really recommend looking at your phone before you go to bed if you can help it. And it can also impact your mood. So, for example, SAD just stands for seasonal affective disorder, which is when during the winter months, especially since we live in Canada and it's the days in the winter at least get really short. There's not a lot of sun. And when we're not exposed to enough sun, that can affect our mood and make us a little bit more moody or sad during those months. That's why it's called the winter blues. But yeah, so the main takeaway here is that sunlight affects sleep via the circadian rhythm. And on the next slide, I'm going to talk a little bit about my own experiences because I thought that that might be fun to share about getting enough sunlight. So for me, I've been trying to make it a habit to get up at about 7 a.m. and go for walks. And it's been really nice because we live in a pretty like rural suburban area. So there's lots of trails to walk on and lots of places to explore. I bring a water bottle with me and I just sip on the water throughout the walk. I usually go for half an hour to an hour walk, and it's really good because you get that water in first thing in the morning, and that keeps you hydrated throughout the day. I don't really listen to any music. I just try to listen to the sounds around me, like the birds, for example, which are really, sometimes you don't really notice it, but once you start really trying to hear, you know it's there. And again, as I mentioned, trying out new routes and exploring the area is really fun. And what I've noticed for myself is that when you spend enough time in the sun and you go outside, that really helps with your mood and your energy levels throughout the day. So I feel more energized throughout the day. I also feel less overwhelmed with the things I have to get done, just more at peace and more calm. So there are really direct, intangible benefits, I think, to getting enough sun and going outside. And on the next slide, we'll be talking a little bit about exercise. So how this relates is because, if you're going outside, you're probably, going for a walk, you're exercising, you're moving your body. So you might be wondering, does exercise affect your sleep? And the answer is yes. And it's pretty simple. If you exercise and you make it a habit to exercise, that can really lead to better quality sleep. So and there are a couple of reasons for that. The first is that if you're exercising, you're probably getting more sun, assuming that you're exercising outside. And exercising also relieves stress and anxiety. And that's because of the endorphins that your body releases when you exercise. So you may have heard of the term runner's high, where after you go for a run, or marathoners, for example, after they complete a marathon, instead of feeling super tired, they actually feel like almost energized. And that's something that you may notice too when you're exercising as well. Like when you're halfway through a workout, for example, you may actually feel that you have more energy than you did at the beginning compared to the beginning of your workout. And finally, exercise tires you out. You're working your muscles, so that's going to help you sleep better at night. And you might be wondering if exercising at night is bad for sleep quality. And the short answer is no, not necessarily, but it could be depending on, your own habits, or I guess what I'm trying to say is that everyone is different. So if something works for one person, it may not work for another person. So we try to say to keep it moderate intensity. So if you're going to go exercise right before you go to bed, you might just want to go for a walk, go for a bike ride, or do yoga. You might want to save your high intensity stuff, your HIIT workouts or whatever it may be, for the afternoon or for the morning. And also track it yourself. So as I mentioned, everyone is different. And if you notice that you're exercising at night and it's not really helping you sleep better, then you can try to track that on a piece of paper. And if you see a pattern, then maybe you can just exercise earlier in the day if that works for you. And the final key takeaway is that habit matters more than time of day. So what matters most is that you're exercising consistently rather than at what time of the day specifically that you're exercising, as long as it's not exercising at like 2 a.m. or 3 a.m. At night, because that's probably not beneficial to your sleep schedule. But that's it for this section.
So one of the things
Okay, so
that
now, oh, sorry.
one of the things that I'd be curious is that I think what improves my quality of sleep is having an active lifestyle, and one of them is exercise. I find that after I exercise, I will sleep better that night. And I'm wondering if Raymond has a comment on exercise and how he feels that fits into people's sleep patterns.
Yeah, certainly exercise daily is important. The best time for exercising for sleep is around 5 hours before you want to go to bed. It raises the body temperature and you fall asleep much more easily thereafter.
Get sunlight in the morning, keep your habits regularly, and exercise. Wonderful. And I got to stop eating at nighttime.
Okay, so we're going to talk a little bit about napping. So you might be wondering, is it beneficial to take naps throughout the day? Well, while you can't truly catch up on sleep missed from the night before, a short power nap can provide you with a burst of energy to get you through the day. In fact, 20 to 30-minute naps are recommended by most health professionals. But it's also recommended to nap early in the afternoon so that you don't have difficulty falling asleep later on at night. Finally, it's also important to plan out when you're going to take naps so that you can keep your body on a consistent schedule. So transitioning into some more, I guess, non-pharmacological approaches to getting better sleep, we're going to talk about setting the mood for sleep. So now that we've made it through a busy day, maybe filled with a nap or two, it's time to unwind and get to bed. In the evening, it's important to take time to decompress, center ourselves, and really prepare ourselves to get to sleep. This will help ensure we're able to fall asleep quickly and help optimize our sleep quality. So I put together a simple acronym called MOOD that can help remind us how to set the mood for sleep. So M is for minimize distractions. This can be done by exiting work mode after dinner. So stop checking your email or worrying about the tasks that you'll have to do tomorrow. Instead, focus on the task at hand, which is sleep, and concentrate on just calming yourself down. Next, as we mentioned before, we should turn off our cell phones, TVs, and other blue light sources 1 hour before we plan on going to bed, as we did say that blue light can disrupt our circadian rhythm. Finally, we should be sleeping in a decluttered bedroom. A 2015 study actually found that those surrounded by clutter were more likely to have a sleep disorder than those in a tidy, organized room. Next slide, please. O is for optimizing your environment. A comfortable mattress and pillow are essential for a good sleep, but whether they're soft or firm is up to personal preference. If you're a side sleeper, your pillow should comfortably support your head, neck, and ears. But people who sleep on their backs should consider a thinner pillow to limit stress on the neck. Furthermore, temperature matters. Most experts agree that the sweet spot for temperature is actually between 16 and 19 degrees Celsius, which is actually pretty cold. I think my house is at 72, which is I think like above 20. So yeah, it's interesting to note that it's between 16 and 19 degrees. And lastly, peace and quiet make for bedroom bliss. So if need be, use earplugs or white noise to block out disruptive sounds. The next O in our acronym MOOD is O for omit evening stress. So we're more likely to fall asleep if we're relaxed, naturally. So take time to do your favorite stress relieving activity before bed. And just some of mine include yoga, reading, and taking a bath while listening to relaxing music. Finally, perhaps the most essential component to falling asleep is lighting. According to the National Sleep Foundation, 73% of individuals say that the darker the room, the better. Do your windows let in a lot of natural light too early in the morning? Consider using blackout curtains. Does your bedside clock give off blue light? Consider using your phone as an alarm. You can even try using a sleeping mask to minimize light most effectively. So that was the little acronym called MOOD, and that is how we can set the mood for sleep.
All right, so next up, we are going to be talking about natural sleeping aids. So basically, these are just natural remedies to give you a little bit of extra sleep or a little bit of extra help to get a good night's sleep. So our first natural sleeping aid is chamomile tea. So chamomile tea is considered a mild sedative because of its abilities to reduce anxiety and induce relaxation. The calming effects of tea may be attributed to an antioxidant found in the tea, and this antioxidant is thought to bind to receptors in your brain that may decrease anxiety and initiate sleep. However, there is no conclusive evidence from clinical trials to show whether chamomile tea in and of itself is helpful. Some studies did reveal that individuals may experience an allergic reaction if you are allergic to ragweed or a related plant. So it is important to talk to your doctor if you suspect that you do have these allergies before beginning increasing the frequency of the consumption of chamomile tea. Our next natural sleeping aid is warm milk. So warm milk can act as a little snack before bed to satisfy any hunger you may have, as hunger can indeed disturb sleep. The reasons as to why warm milk may be helpful in inducing sleep are that certain compounds found in milk can promote relaxation and function as a precursor in the production of a hormone called melatonin, which you've heard a couple times already in this presentation. It's often referred to as the sleep hormone because it helps to prepare the body to enter the sleep cycle. And again, although there's no evidence that shows that a single glass of milk can do all of these amazing things, having it every night before bed can create a kind of calming psychological effect. So having a relaxing pre-bedtime routine can help you feel relaxed and fall asleep a little bit easier. Something important to note is you want to be careful with liquids before bed. So whether that be warm milk or chamomile tea, as it might wake you up to use the bathroom and also add to your caloric intake. So before continuing on to our next sleeping aid, if Dr. Gottschalk wouldn't mind, I'd like to ask if he has any recommendations regarding liquids before bed. So for example, how long before bed that it's okay to drink these liquids, or even if it's recommended at all.
No, the simple answer, and I'll keep it brief, because no fluid before bedtime. It's just going to, we reconstitute fluid from our body and we will urinate and then we'll wake up. So I certainly don't recommend that to anyone.
All right, thank you. Thank you. Our third natural sleeping aid is magnesium. So magnesium is a common mineral that is found in many foods already, such as green vegetables, nuts, meat, fish, fruit, as well as in your drinking water. So every cell and organ in your body needs it to function. On a more specific chemical level, magnesium works to activate your parasympathetic nervous system. So this system is responsible for getting you calm and relaxed. And by activating the PNS, or parasympathetic nervous system, it helps to quiet down your nervous system so that your mind and body can prepare for sleep. It also helps to regulate sleep hormone melatonin that we've already mentioned, which again helps your body to enter the sleep cycle and helps you achieve a deep and restful sleep. It's very important to talk to your doctor about beginning or increasing the consumption of magnesium, as seeing as with any supplement, including magnesium, which may cause side effects or interfere with certain medications you're taking. So you want to have that discussion before adding that onto your bedtime routine. Another natural sleeping aid is actually to avoid something. So you want to try and avoid alcohol and smoking. Beginning with alcohol, it's important to remember that although alcohol might make you feel sleepy, it should not be used as a sleep aid, as it can result in alcohol dependence and will ultimately disrupt your sleep. In low to moderate doses, alcohol isn't harmful to sleep. However, chronic use will disrupt sleep-related physiology. So some of this physiology that I'm referring to include the fact that your liver works to metabolize or break down alcohol throughout the night that you might have had before bed. So as your blood alcohol level decreases throughout the night, it might cause individuals to have sleep disruptions, decreasing your sleep quality and making you feel sleepier throughout the day in case you woke up through the night. Also, alcohol can cause imbalances in your sleep cycle, such as reducing the amount of time you spend in REM, which we learned about earlier in this presentation is a very important part of your sleep cycle. Moving on to smoking, nicotine, which is found in cigarettes, is a stimulant and is highly addictive. And because of its addictive nature, one may experience withdrawal symptoms throughout the night and causing you to wake up and disrupt your sleep. And because it is a stimulant, if it's used too close to bedtime, it can contribute to problems falling asleep. Another helpful sleeping aid is to listen to music. So listening to music while falling asleep can improve what's called your sleep hygiene, which is your ability to fall asleep quickly and feel more rested. So thinking back to a time when you were a kid or when you're helping a kid to fall asleep, you would sing a lullaby or a gentle rhythm to try and help them to fall asleep. So luckily, adults benefit from this calming music before bed as well. It can improve the quality of your sleep, decrease the amount of time it takes you to fall asleep, as well as your sleep efficiency, which means more time that you're in bed actually asleep versus kind of tossing and turning, resulting in a more restful sleep. But why music? So music has been known to decrease levels of cortisol, which is a stress hormone. So being stressed while trying to fall asleep and having elevated levels of cortisol pumping through your body can increase alertness and lead to poorer sleep. Whereas music will reduce the levels of cortisol by helping people to feel at ease and release their stress. Music also triggers the release of dopamine, which is referred to as your feel-good hormone because it's released during pleasurable activities. And this release can boost good feelings at bedtime, and we all know it's a little bit easier to fall asleep in a good mood versus a bad mood. Music also soothes your autonomic nervous system, so leading to slower breathing, lower heart rate, reduced blood pressure, all of which help you fall asleep. Now, the genre you choose for your music is totally up to you and your preferences. Most studies will suggest a tempo of around 60 to 80 beats per minute, but any songs that bring you peace and are relaxing to you will likely be effective for you. So those can be classical pieces, piano pieces, whatever brings you the most peace. And try and make this a habit. One very important note, though, is to try and use a speaker instead of earphones, because headphones or earbuds might cause damage to your ear canal while sleeping if the volume is too high, and also can increase the risk of wax buildup and potential ear infection. So you want to try and use a little speaker or radio instead.
Sorry to interrupt again. The meeting's just going to end again, so let's refresh the meeting again. So we'll take another 2-minute break, and I'll just restart the meeting, and we can all join back in about 2 minutes. And we are live.
So how to sleep better, some natural areas that we talked about. Breathing. Let's hear about breathing.
All right, so our last natural sleeping aid is simply breathing, which I've forgotten to do during this presentation, so I apologize if I'm speaking too quickly. The 4-7-8 breathing technique, to be specific. So this is a breathing technique that helps you to achieve relaxation. So think of this technique almost as a natural tranquilizer for the nervous system. And by this I mean that unlike actual tranquilizing drugs that lose their power over time, this exercise is subtle when you first try it, but gains its power over time with repetition and practice. So you can use it whenever something upsetting may happen or for the purpose of this presentation to help you fall asleep. If we could go to the next slide. Thank you. And this technique is super simple. You're first going to begin by closing your mouth and inhaling through your nose for a count of 4. Then you're going to hold that breath for 7 seconds, and then exhale completely through your mouth, making like a whoosh sound. So for a count of 8. And then you repeat the cycle 3 more times for a total of 4 breaths. And if you feel like you can't hold your breath for a full count of 7, that's 100% okay. The time you spend in each phase is not important. It's more so the ratio. So you can speed up the counts of like the 4, 7, and 8, And then with practice, you can slow it back down and get used to inhaling and exhaling more deeply.
Now let's talk about mindfulness practices to help you sleep better. Mindfulness is all about being in the present moment rather than living in the past or getting caught up in the future. When we're being mindful at bedtime, it gives us some time to unwind and focus on getting rest. So, have you ever found yourself staying up late because you're too busy thinking about how your day went and what more you could have done or what you shouldn't have done? When we get so caught up in the past or the future, we don't actually end up giving ourselves the permission to rest. So, with mindfulness, the emphasis is on being present and being deliberate with our decisions. So, when it's time to sleep, mindfulness looks like giving yourself the permission to rest. It means unplugging at least an hour or so before bed, and this could be from your phone, from your worries, from everything that is distracting you from simply resting. One wonderful way to incorporate mindfulness during bedtime is to create a nighttime routine. And this could look very different for very different people, but I will share mine as an example. So, what I like to do is a mindful skincare. So this means I go to I go to the bathroom, wash my face, apply my skincare, and during this whole process, I try to my best just to focus on how my skin feels underneath my hands as I wash my face or apply my moisturizer. Now, after that, I like to tidy things up a little bit. So some nights that means cleaning my entire room, while other nights that just looks like dusting off the crumbs from my bed and lying down. Another thing I love to do is to consider my future self. It's another form of self care, but it kind of has a motherly touch to it. So, for example, if I know I will shower in the morning, I will have my towel and clothes set aside the night before, ready for me when I wake up. For you, it could look like setting your medicine on your nightstand and with a water bottle so that when you wake up, you don't forget to take your medicine. It's essentially about taking a moment to consider the tomorrow you and what they will be up to and how you can make their life easier. Now, just to reiterate, the nighttime routine can look different for everyone. So you could listen to music, read a book, or do anything that will help you relax and get sleepy. One other thing that could really help at bedtime is meditation. Next slide, please. Meditation is so beneficial for our health and our sleep, and this is backed up by science. Research shows that it helps increase melatonin, which, as we talked about many times, is a sleep hormone. It helps increase serotonin, decrease heart rate and blood pressure, and also activates the part of the brain that controls sleep. Aside from its sleep benefits, meditation in general has been found to improve mood, relieve stress and anxiety, increase focus, reduce tobacco cravings, reduce physical pain symptoms, and so much more. Now, let's summarize everything into 5 tips to sleeping better. Next slide. So the first one is sunlight, steps, and sleep. So at least 30 minutes to 1 hour of sunlight exposure and moderate intensity exercise before bed. Number 2, napping. 20-minute naps early in the day are ideal. Number 3, setting the mood for sleep. So minimize distractions, optimize your environment, omit evening stress, and darken the room. Number 4, natural sleeping aids. So that could be warm milk, chamomile tea, magnesium, 4-7-8 breathing. And number 5, mindfulness habits, establishing a sleep routine, unplugging before bed, and meditation.
Perfect. Thanks so much, Sophia. So originally the plan was to do some meditation today, but for time's sake, we're going to be having a video uploaded next month from the Mindfulness and Wellbeing Club, and it'll be a meditation that's geared towards being able to use it for sleep. So look out for that next month. And that concludes our presentation for tonight. Thank you everyone for watching. Dr. Gottschalk and Dr. Kearney, if you have any last words, please feel free to go ahead.
From my side, no, thank you. You did a really good presentation. That was excellent.
Thank you so much for attending with us.
That was a very comprehensive tour. Is that you start off with this world sleeping 16 hours, and then life gets in the way, and then we sleep less. But I think I'm learning to calm my nerves, sleep better, and using more behavior. Is that there's no magic pill that's going to really help most of us sleep better, but changing how we focus our relationship with sleep is important. Also, that sleep apnea it can be a very severe medical problem, and if you think you have that, get the proper investigations, learn how to use that well. So for most of us, is that you start the day in sunlight and you end the day in darkness and restfulness. So I just want to thank the entire crew. Very comprehensive. I think we did like 12 modules in today, and learned so much. And a special thanks to Hannah and her team. Thank you, Jerry, for filling in today. And Dr. Gottschalk, thank you so much for all your insights. You taught us a lot, and we really appreciate it. I want to wish everybody a good night, and I'll give you the final words. Any words of wisdom you want to impart tonight?
From me, no. I think people should just follow this program. It's excellent.
And thank you all so much, everyone. So I got to bid everybody a good night, and fantastic. And thanks to the team, and sleep well.